The big gap in the US for cancer survivors is in mental health. By focusing on AI as a tool towards better communication and understanding, it's more than just, empowerment as a vague category, but it really will, I think, help people feel they are better prepared to handle the many challenges that often happen to the individual and the family after a diagnosis of cancer. Survivorship is an ideal testing ground for many of the AI interventions that I see being rolled out.
Do you ultimately think that these tools will still be a discretionary tool that every individual physician would be able to choose whether or not to leverage?
Where I see this going is that it's...
When someone is diagnosed with cancer, care quickly starts to orbit around the protocols. Diagnostic pathways, treatment regimens, surveillance schedules, and clinical decisions made under enormous uncertainty. But what about the life happening all around it? The fear, the relationships, the work, the identity shift, and what it actually means to live after cancer. That's what today's conversation is really about. My guest is Dr. Lidia Schapira. She's a professor of medicine at Stanford and the inaugural director of Stanford's Cancer Survivorship program, one of the leading efforts in the country focused on helping patients live well with and beyond cancer. She also shaped how oncology and the oncology community communicates with patients, serving as the editor-in-chief of Cancer.net, ASCO's patient education platform, and for more than a decade as the editor of the Art of Oncology section in the Journal of Clinical Oncology. In this episode, we talk about why survivorship care is so hard to embed into standard oncology workflows, the cultural resistance to change, gaps in training, and the tension between disease-focused care and whole-person care. And then we go straight into the cultural moment we're living through right now, AI in medicine. Dr. Schapira makes the case that survivorship may be the ideal proving ground, not just for AI scribes and documentation, but for tools that help patients prepare before visits, debrief after visits, and participate more fully in shared decision-making. This is a really special conversation. It's about the art of medicine, communication, judgment, presence, and how AI, if designed thoughtfully, can strengthen those human elements rather than replace them. Can we start by just telling us a little bit about yourself and how you got to where you are today?
Be happy to do that. So I am a classically trained hematologist oncologist. I went through a fellowship and research time and then found my niche in the care of women with breast cancer. So I've been sort of an academic oncologist for many years. And I was very interested always in what I'll call the human side of medicine and the human side of cancer as an illness, as an example or prototype of a serious illness. So in addition to being an academic oncologist, my area of interest, both for research and advocacy in my own writing, has really been in the patient's lived experience and how doctors and patients communicate, make decisions together, grieve when things don't go well, and how we teach this to other generations of healthcare professionals. So I've landed in an area more of psychosocial oncology. I've specialized in trying to understand the experience of young women diagnosed with breast cancer. I've taken a detour and edited narratives that have been sent to medical journals such as the JCO. And then for the last 9 years, I've been at Stanford at the head of a new program focused on what we call survivorship. And survivorship actually is forward-looking, thinking about how somebody lives after they've been diagnosed with cancer, living with, living beyond, but all of the multiple issues that occur as a result of having been diagnosed and treated for cancer.
Yeah, that's why I'm super excited for the conversation today. I mean, when I kind of first discovered some of the work that you've done, it really kind of moved me because, I shared with you my story with my mom and her breast cancer journey. And that was this kind of side of medicine that I think, as somebody that isn't clinically trained, really kind of stood out to me, right? When I was helping my mom with her treatment, I just felt like a lot of healthcare became lost in the science and the administration of it all. And when I would talk to my mom, that's really wasn't really what she cared about. And so when I was learning about the work that you were doing, I was like, I wish this existed when my mom
Yeah.
was going through her treatment. And yeah, it just really moved me. So, first, I just want to thank you for all the work that you're doing. And, I'm super excited for kind of digging in. So I want to dig into a little bit more about kind of this survivorship program at Stanford.
Mhm.
Can you tell me a little bit more about kind of some of the changes that have really come about through the founding of kind of this center, and what is the kind of focal point of the work today?
So the focal point is the patient and what happens to the patient. And in the academic work that we've done, both educational and programs, we've sort of focused on what we call finding health or health after cancer as a way of addressing sort of the mind, body, spirit of a person. Like what happens and what is it that people need to do to go on and live as well as possible, as long as possible. So, a lot of what we've done is create a transdisciplinary research program. We're working with people at the university in the mind body lab on interventions that will help people adopt a useful mindset when they're diagnosed with cancer to help them feel they're capable of managing the illness. And we have some very exciting clinical trials in progress in that area. We're working with a psychologist currently at the UK on an intervention designed for young cancer survivors to help them actually understand what they're feeling in their body when they're feeling anxious about a cancer test or afraid that the cancer might come back. So we're taking it to that level of trying to really think about the experience, what we've learned with the ear to the ground of the lived experience of people with cancer, and trying to address it in ways that can help as many people as possible. We're also looking in our research at late effects of cancer and how people can live with some of the complications of cancer therapies, which we know, unfortunately, often have a litany of side effects, some that happen during treatment and some that can happen later. We're also thinking about models of healthcare delivery, like what happens to people with cancer once they're out of their active treatment. And we've built a wonderful faculty practice for cancer survivors. So they are not only providing care and consultation, but they're helping us understand what it is that we want healthcare professionals to know, and then
Wow.
translate that into coursework and lectures and so on. And then on the operational side, working with operational partners to think about delivering at least some form of survivorship care in the cancer center before people leave. So, based on their risk, some people may need more, some people may need very little or nothing, but based on their risk, to try to link them to a healthcare professional, nurse practitioner, physician, nurse navigator, nurse coordinator, who can help them sort of put together what they need to know to help them then when they're sort of out of the active cancer care, what tests they need, who to call for what can happen, what to expect. And, this is all not something that you can all sort of switch on and off very quickly, but we're building a lot of these different programs and research portfolios and helping shape the careers of some of the younger academics. And very importantly, sort of creating a culture shift on campus. There's so much excitement about cancer discovery. We're trying to create the same buzz of excitement about thinking about the individual and everything that will come later, and try to have some of these conversations even earlier on to prepare people for that moment when, hopefully their cancer treatment is over. And if it's not, to live with it as well as they can.
It's really thinking about the patient's life context and thinking about what is the lived experience of having to go through such a traumatic time or moment in their life, and helping that patient navigate that. I'm curious, like in the implementation of some of the programs that you guys have built, are they like kind of interwoven into the standard patient journey, or is it more kind of like a program that the patients can opt into or the providers like recommend? Or is it really kind of more of a ubiquitous thing where it's like, hey, like we changed the way we practice medicine for all oncologists at Stanford because of the research that you guys are doing at the survivorship program?
So some of what you said is aspirational for me. I would like it to be the latter, that we've actually changed the way everybody practice, but the reality is not that. So the reality is that we are trying to embed some level of survivorship care into the clinical care programs that welcome us. So not
Mm.
every clinical program has opened their arms and their doors to receive what we have to offer, but some have. Some groups, lymphoma, bone marrow transplant, breast cancer, GYN oncology, some of the groups really are more have been more receptive or quicker to adopt. And I think the others probably will follow in some way. So the answer to your question is some of what we've created has been sort of translated for the greater good of patients entering Stanford, as we have, argued for more supportive services that relate to, say, sexual health or perhaps family building or rehabilitation, but some are really more focused on certain populations of patients because we think at Stanford and most academic centers, patients think of their clinical care program, which is still disease focused, as their home. So we're trying to embed some survivorship care where they have received their cancer care rather than sort of outsourcing and saying, now you go to a general survivorship clinic, so that we continue with the expertise of the clinicians who are actually treating the disease and have perhaps an existing relationship with that patient and family.
Yeah. I mean, to me, it sounds so obvious, right? Like, and I guess in healthcare, sometimes I've been surprised many times of like, wow, like it's so obvious. Why aren't we doing that?
Yeah.
And it's really interesting to kind of dive into some of the reasons and like, I'm curious, like, why do you think some, um, welcome this idea, whereas others have been harder to find adoption? You mentioned payment models, you mentioned, just the focus on like really kind of the drug discovery side of it. Like, what do you think it is that needs to change in healthcare for this to be viewed, ubiquitously as like an obvious thing that we should be doing for patients?
That's a really interesting question, I think. Part of it, I think, is that at least I'm going to talk about my own tribe, the doctors and the cancer specialists. They're very reluctant to change. If you study them as a group, we don't accept change very easily. And I will say for my colleagues, and something that I've felt as well when we were starting this is, hey, I'm an expert in the disease. I know what my patients need. And what gets missed if you have that kind of a mindset or attitude is that there are so many other things that happen to people. We, the oncologists, aren't get great at, say, motivational interviewing, counseling, addressing some psychosocial needs, addressing return to work, addressing problems of intimacy, addressing problems of relationships. So we should open up the discussion and then refer. And that's part of the survivorship charm, is that the conversation is broader than, do you have cancer? Do you not? Are you tolerating your medicine or not? When is your scan due? Let's schedule it, which is typically the context of cancer focused visits. And it's not that there isn't lovely chatter, and it's not that we don't care about the dogs and the kids and the grandkids and the graduations. We do, but there are some certain skills that need to be brought into that visit that are part of the survivorship package and not necessarily part of just the regular cancer follow-up package. And that's, I think, whereas many of my colleagues in the cancer world sort of aren't sort of participating in this conversation. On the other side, our primary care colleagues are saying, hey, we've got a lot to do. Why do we need to absorb this? And the answer is because there are so many cancer survivors and because you already have these patients
Uh-huh.
in your panels. So just see if you see cancer in the problem list, don't think of it just as something that the oncologist is going to do. The primary care, we want to be engaged as well. It's better for the patient, it's better for everybody. And those are the challenges, as we're dealing with a culture that is reluctant to change. We're often asking people to do things that they weren't trained to do, but it's all for the benefit of the patient.
I think that's an interesting segue because right now we're in such an interesting cultural moment with the advent of AI and the wide adoption of AI, and we spent some time talking about this, before the podcast, about that adoption is not just on the physician side, but it's also on the patient side, and so I'm curious to kind of get your take on how what this moment means for the work that you're doing, and what are some of the opportunities where you think that survivorship can be kind of introduced into the conversation of the AI adoption that we're starting to see in medicine today.
I think survivorship is an ideal testing ground for
Hmm.
many of the AI interventions that I see being rolled out. First of all, we can start with the work that happens in the clinic. So, the patient clinician interaction, where AI scribes already are being used to relieve the clinician from some of the burdens of documentation. And that's great. And we can do it. But the question is, how good is it? How good is it for the patient? How good is it for the chart? How good is it for the clinician? And I think that that's where we can think about the skills that the clinicians need and may not have to use that AI properly, and how to train the AI to be better so that the AI makes fewer mistakes in the documentation. And we're not there yet. And the clinicians need to develop skills as editors, which they may not have if they're just charting. So, developing some editing skills, being more careful to avoid AI transcription errors that may create misinformation in the chart itself. So there's a lot of work that we can do, but if we do it well, then possibly the charts can be easier to read, both for the patient in the new era where patients can access their records, but also as a way, as I think of the chart, of transferring very important information from one clinician to the other if that patient ends up in the emergency room or needing to see somebody who doesn't really know their history very well. So that's one way of thinking about AI. The other is the very interesting question I think that you're alluding to, which is how can it help empower patients? And I don't think we know yet. I think we've barely scratched the surface. I can tell you that I think AI, for instance, can help us by very quickly providing checklists and lay language summaries for patients that are
Hmm.
based on good scientific publications, or help us map the patient's trajectory onto guidelines so the patient can see where the recommendations are coming from. Hey, there's a body of rigorous evidence that's been dissected and analyzed by panels of experts that have, allowed us to create these evidence-based recommendations. And this is how they apply to exactly your situation. And I think that's where sometimes, we have felt that we don't have the time or the tools to do it. But I think AI can help us do that in real time so the conversations can be better informed. The patients, then really have more information to allow them to make the right decisions for them. But we need to train the clinicians to think about this. This to me comes back to the very first thing I said to you, which is to how to think about the practice of medicine in this particular situation with people with cancer as a collaborative enterprise where we can learn together, learn from each other, and where an AI, I think, can help us import good evidence into that moment, into that place where the care is being delivered, and then how patients and their family members can use AI after the visit. That is something I think we haven't really discussed yet.
Yeah. I think it's a super interesting concept. And ever since, I started the company like 8 years ago, it's been a concept that we've talked about, right? Was like a lot of this isn't just about helping unburden the physicians from documentation. It's this idea that by recording these conversations that you have with your physician, it creates this latent space where you're able to summarize that information in ways that are purpose built for whatever that use case is. So if it's the patient needing to understand the care that the conversation that their provider talked to them about, they can chat with that. They can, we can convert that conversation into, a reading level that the patient can understand. If so a researcher wants to understand this conversation, they might be pulling information that's different than what a physician would think is important to write down, right? And so it really kind of creates this new opportunity where we can improve our understanding of healthcare and how it's being administered. I think the question is what is the first application of this, right? I think for me, like we would love to build a patient facing application and
Mhm.
help empower these patients. I think the struggle that we run with is all the drudgery of healthcare, right? Where you start talking about malpractice, you start talking about liability, and these are serious questions that you need to be answered. And that's why I think, if you look at the adoption of AI in healthcare, you start seeing like this matrix where you kind of map the risk level of the application or the use case, and then all the impact. And the reason why scribes have kind of really reached this level of adoption that we have is because it's relatively low risk because the physicians need to review and sign off on the notes. But it's relatively, it's the highest impact. When I talk to physicians, that's the thing that they hate the most, right? And I think we're finally getting to the point where we're reaching a critical mass of the adoption of these tools, where it's creating this cultural moment where these physicians are now saying, "Hey, like I didn't like change, but this one change really helped me. And so what else can I change? What else am I missing out on?" And I think that's where, we as technologists and as, academics, as experts need to come together and really make that decision. Because without that partnership, I think where a lot of the direction is going is, just simply where the money flows. Right. But I think when, I learn about the work that you do and, some of the conversations that we've had previously, it's almost like there's a new opportunity to again understand how care is being administered, and how can we use that to improve the outcomes for the patients, right? And that should be the focal point.
I think that the high level theme here is that the AI scribe helps billing. And if it helps billing, then the systems will invest in it. So there are two things that it does. It relieves some of the pain of documentation, which has been imposed only to serve billing purposes, not because we are gotten better at the narrative practice of medicine. So it helps the notes conform to the highest billing level, which brings in the revenue to make it something that institutions will provide. And they call it a service to clinicians, but in reality, it is to help with the flow of funds. So let's just be really clear about that. I think we can piggyback onto that and say, okay, fine. And now let's help the humans here. And then that's the part that I think that your quest, it resonates very deeply with me, because I think that it's there. It can help us with language. It can help us by demystifying the medical care, removing some of the jargon, maybe producing lay language, summaries, providing checklists, providing tools and resources for patients. Again, using the real capability of AI to search the evidence, if we train it properly, to help us counsel the person in front of us who may just want a recommendation from the oncologist, but who may have a son or daughter who's a PhD student in mathematical probability somewhere and wants, real data. So the point is beginning to have a different discussion about the patient preference, the expectation of benefit, thinking about how AI can help us, bring that into the conversation, record that in the chart, guide the patient to the proper resources. And guide is the real operative word here, because I think also AI now has helped the patient have a direct relationship with technology and data. And they often think that this is something they do on their own, and then they don't tell the clinician. But I think that's where we can think about, building communication channels and bridges to help us all have the same conversation.
Yeah. Do you think that, like, if you were sitting in my shoes, right, deciding what the next thing to build, what would it be, right? Like, would it be more around, how can we use this to educate patients and understand their care? Would you use this technology to help physicians understand the way they practice and help them, improve the way they practice by giving them feedback on the bedside manner and the words that they're using? Would you use it, like, there's so many different applications that we can do with this. And, I shared with you some of the ones that we're working on, but I'm curious, if you were in my position, like, what would be the first thing that you would prioritize?
And my mind is spinning because I'm thinking of all of the things that you could do, but I don't have your knowledge and your skill set. But I think on the providing physician feedback side, I think there are lots of things you can do. I've seen some work of, colleagues and so on, for instance, that help the physicians, for instance, point out by pointing out, for instance, where they're stereotyping or where their language they're using to describe a patient, may actually be making assumptions that, shouldn't be made. So I think providing feedback in a way to, help the physician with the way they think about it, the way they enter things in the chart would be incredibly useful. And the other is, I think I don't know if this is something that you can do, but maybe in collaboration with the clinicians, is decide what language belongs in the medical record. I love narratives, but for me, the medical record is not a place for narrative as much
Mm,
as for, the briefest way of conveying information and removing things that are redundant and no longer necessary. So I think if AI could make us smarter in how we document, could provide some feedback, like, you don't really need to say that. You've said that 3 times already. Why don't I remove two of these statements, and just, ping it there? Or if the focus, for instance, if it could allow us to be more focused, if the reason for bringing the patient in is to assess if they're tolerating a treatment, then let the content be about the tolerance of treatment. If there's anything else that's super important, fine. But if not, if we can just hone in and be more precise in the use of language that helps us give better advice, boy, that would be good. AI can be brought in some way also to help the patient express themselves. Maybe the patient doesn't quite know how to say things. And it could be just that, they don't speak our language, they don't speak our jargon. And I wonder if AI could, using proper training and language training and so on, help us, find ways of really making sure that we're understanding one another. Because I think the modern clinician is so checklist oriented that they just want to check things in boxes, and they've stopped listening sometimes. And that also may mean that they're not having, that their interactions with patients are, more transactional. And at the
mhm,
end of the day, nobody is happy with that.
mhm. Yeah, it's interesting. It's like using technology to make us more human, right? It's freeing us up and illuminating some of the parts where it's like, wow, like I feel like a lot of these things when you tell somebody that you pick that up, um, it's not like you're telling them new information a lot of times. It's like, oh, I just forgot, right? Or I just like had I known, I would have done it, right? And it's really about not trying to, change the way that they practice because for the sake of changing it. It's really helping them to, do what they sometimes already know what to do, but just making sure that you're reminding them and nudging them along to practice at the top of their license.
Yes.
Yeah.
So along those lines, if we could use AI to help the patient prepare for the visit and then help the patient debrief after the visit, maybe we could help in that way. And I haven't seen any experiment that actually uses AI in that way, but I think it could be designed.
Yeah, maybe we'll do something together. A lot of the stuff that we've been talking about to me leads to a world where ultimately AI assisted care or care that's delivered with the assistance of AI um, will ultimately lead in a better patient experience, would ultimately lead to better clinical decisions, ultimately lead better to better patient outcomes. And I think it's easy to imagine that world, right? And the question that I have is really in that world, um, do a lot of these tools become compulsory for physicians to leverage as part of the standard of care? Or do you ultimately think that these tools will still be a discretionary tool that every individual, physician would be able to choose whether or not to leverage?
My thought, not based on a lot of knowledge, but where I see this going is that it's going to be part of the delivery of care, and we just haven't quite figured out the extent, because there's sort of different levels of adoption and different levels of comfort. But I think this is going to be part of the delivery of care. I mean, we've moved from, in my time, say, as a specialist, we've moved very much from the dyadic model where it was communication. When I thought about it, was my patient and communicating with me, to understanding that there are many other people involved, and now basically to a team-based care model. So if you are, researching health
Mhm.
services and implementation, it's all about delivering care as a team. And I think the AI is going to be part of that construction of the team. So I think that if you ask me, I don't think it's going to be optional. I think it's here. I think the smarter practices and forward looking systems are going to be pushing what the AI can do to serve. And I think that that's the part that I'm very interested in. The evaluation of AI. What is it really costing us? What is it really doing for us? How is it impacting on patient satisfaction? And in the case of cancer and cancer survivorship, which is my field, my perspective and or my slice of this action is it empowering patients to be healthier, to feel more capable about handling their health? Because we know we've now handed them after cancer all of these other health challenges. So,
Mhm.
how can we prepare them to navigate a fragmented healthcare system and advocate for themselves and know what it is they need to do without needing to professionalize their illness? And I think AI can help us.
Yeah, it's a world that feels like, to me, obvious, but I sit on the side of the table. I live in San Francisco. When everyone comes and visits me, and they're like, Matt, you're crazy. um,
No, I don't think
uh,
it's crazy. And I think that thinking about the role of AI, I also think about it not just in our wonderful, highly resourced environment in the Bay Area, but globally. I mean, AI can really help bring up the level of care in many places where there are fewer resources than what we have here, both in terms of the workforce, the trained professionals, and the systems, what the systems can do. So I think AI can play a major role in actually sort of elevating the general standard of care of people with cancer everywhere. And I very much hope that somebody is going to be interested in moving that effort along.
I totally agree with you, and I think the health equity piece is really kind of like the core of how I view the accuracy and how you should evaluate these tools, right? I think a lot of times when I'm speaking to academics and regulators, they're always asking me like, "Wow, like AI is hallucinated this one time, and as a result, we need to eliminate all hallucinations, and we should slow down the rollout of this technology." And I like to tell people that it always surprises me that people hold technology to a higher standard than they hold themselves, right? And I think that the way that we really need to be evaluating these tools is like, is this more accurate than the average oncologist, or is this more accurate than the average provider? Because a lot of times people think that the humans are the most accurate ones, right? And I think there's like a really interesting analogy that's starting to take shape in San Francisco, where all these self-driving cars have kind of taken over the streets. And I read this really interesting article that was comparing like the number of accidents per like million miles for the self-driving cars versus the number of accidents per million miles of the average human. And I forgot the exact numbers. I don't want to misquote, but I think it was like more than an order of magnitude. Right. But still, right. Like if you think about the regulations that the self-driving cars need to go through to get their cars in the road, I think they just all started letting them on the freeway. It's so interesting. And to your point about the health equity piece, like it's not really, to me, just up to the systems, right? I think at a certain point, and we're starting to see this with the patients, is that the patients will demand it. The patients are like, wait, my other doctor gave me their undivided attention because they're using an AI scribe. Why aren't you using AI scribe? And why are you staring at the computer? And why am I looking at your back? And I think that hopefully is the type of like push that we need from all sides, right, to try to accelerate the adoption of these technologies.
Yes, I think that there are a few things that come to my mind as you were talking. One is the ethics. When these self-driving cars are programmed, there are lots of ethical questions that can be posed in a situation where there's an object.
Mhm.
Who who's who comes first? Who needs to be saved?
Yeah,
If there's a toddler coming by,
yeah.
and there's an older person crossing a street, what does the car do? So, I mean, I know this is very simplistic, and you clearly know that I'm not somebody who's an engineer who's training cars, but the point is that the instructions for the self-driving cars, because of the enormous power they have
Mhm.
to both help human beings and also to destroy human beings, needs to be factored in. So, the AI scribe isn't going to kill a patient, but if it records misinformation or it doesn't capture what's going on, it could lead to bad advice. So I think the ethics of this have not been properly discussed, but should be aired. I think the point of view of the patient is fundamental in developing, these new iterations of the AI. I'm struck that in the last 30 years, we've recognized that the patient actually has a voice and can tell us what's important to them.
What a
It's like,
surprise.
it's like, wait, what? But I was just at a medical meeting in Texas, where the breast cancer community comes together at the San Antonio Breast Cancer Symposium, and that is one highly scientific global meeting where the patient advocates and the patient representatives have a role on the stage at every presentation. And they are asked and invited to comment, and those comments help us interpret the findings, but they also help inspire and refine the ideas for new research. So I think this is a model that we can bring to this conversation when you say, what should your company be working on? Or, what kind of experiments should we be designing? I think that we need to bring the patients into the co-design and ask them directly. And when you were talking about the setting, I can imagine the exam room where all the patient sees is the physician or the clinician's back as they're interacting with their computer. I'll tell you this, even again, when we started bringing computers into the exam rooms, which is now decades ago, I remember some very sort of forward looking clinician humanists who actually asked the patient to sit next to them and
Mm.
co-edit the note as it was being written, as a way of saying, I have to do this work, but that shouldn't interfere with us working together side by side. So I think creative clinicians who really understand the human side of medical practice will find ways of humanizing AI, and will find ways of, helping design the new tools to to finally help the patients. But we need work on this. We need to, I think, to make this change happen faster, and think about the ethical side before somebody just runs away with a good idea and tells us all that we need to do it.
Yeah. What do you think that looks like in terms of setting up that feedback loop, right? Like, what I would say, like some of our most successful partnerships have really come from just asking the physicians. Like sometimes we like to say like our product is built by our users. Like every single feature, every single placement of the button, the color of the app, the type of font we use, it's all picked by our users. And
Brilliant. But I think that if I understand our conversation properly, you want to expand that space. And
Mhm.
in that new space, you now are going to find a new partner. And the question is how to make this, instead of dyadic, you and your physician or clinician user, to bring it in also so that that content can be put to use by the patient and the patient's network. And that is the next challenge, right? Because it has to conform to confidentiality and privacy standards, and it needs to have, a very clearly stated purpose. And if the purpose is to educate, inform the patient, then I think that, your incredibly smart team can design something that will meet those criteria.
Yeah. Yeah. I mean, I think in some sense, now that I think about it, it might be easier because, getting time with oncologists, it's very difficult. But at the end of the day, we're all patients. And so there's a larger population of patients than there are physicians.
So a starting place that occurs to me, and feel free to ignore this, is to prepare the patient for that visit.
Mhm.
So to use AI to interact directly with patient by doing the equivalent of an symptom assessment, providing a summary of the last visit, asking the patient, prepping the patient or nudging the patient to formulate the questions they have to help build good language that the clinician can understand around that and prepare that. So that's the first thing the clinician sees, and that might just allow for a better conversation.
I'm curious, Dr. Shapiro, so, I had a guest on the podcast, Dr. Leyland Wilfong. He's the head of value-based care at a company called Time Care. And, we spent a lot of time talking about how the current, payment models don't really incentivize a lot of the important scaffolding that's required around the patient to navigate care. And what it sounds like to me is, a lot of um, this patient empowerment, these tools that we're building for the patients, sit kind of on that side of the fence. And I'm curious if you think that as part of this change, you also need, this kind of tidal change of the payment models. And I guess my question is, how do you think that this work is incentivized and paid for if it's not under a value-based model, or does it need to be?
So interesting. So I'm not an expert in value-based care, so please forgive me, but just thinking about what it is that we're trying to solve. Again, my entire career and my clinical work, my research, everything is to serve the patient. So ultimately, it's how does this benefit the patient? In terms of the efficiency of devoting some resources, or the cost argument of devoting resources to empower patients and prepare them, I would say it will reduce the time that your paid workforce, may need to spend with a patient. It may reduce the number of messages that are coming in through the portal. It may reduce the phone calls. It may reduce the urgent care visits. So for some, that's an important model. It depends on, what the economic model is for a particular practice. But I think that that is important from a societal point of view. If it keeps more people out of ERs and keeps people healthier and helps them make choices that lead to healthier lifestyles, it's a good for everybody, right? There'll be less days lost in productivity because of absences from work. There'll be, a more engaged, adapted public. And then from what I've seen in the world of cancer survivorship, the big gap in the US for cancer survivors is in mental health. That comes across, in every single study in every population. People experience trauma that keeps on giving, and we don't have enough referrals. People don't have access to good therapists who are trained to work with this. And I think that by relieving some of the earlier distress, helping people feel they're more capable, facilitating better communication, we may be able to prevent, or in a way, provide some help for people who are struggling after being diagnosed with cancer, or family members who are left with questions.
Indeed.
Because it affects not just an individual, but of course, every cancer diagnosis affects a family. We see that in our research with, parents whose kids were treated for cancer. They feel they were never given access to enough mental health to help them afterwards. And they're carrying some of these feelings and guilt and all sorts of other things for a very long time. So I think that by focusing on AI as a tool towards better communication and understanding, it's more than just, empowerment as a vague category, but it really will, I think, help people feel they are better prepared to handle the many challenges that often happen to the individual and the family after a diagnosis of cancer.
I feel like identifying those things early, treating them early, it's really a matter of prevention,
Mhm.
right? And that is really kind of the fastest path to bending the cost curve. And so I think it's just a challenge of how do you develop the evidence of that? One of the things that we did at DeepScribe was we worked with a company that did vocal biomarkers, and they were able to use a 30-second voice sample of the patient that they can harvest from the conversations that we're recording to diagnose a patient with depression, Alzheimer's, PTSD, these neurodegenerative disorders. And it was such a cool idea. Like when I heard of this, I was like, this is the future, right? Like we need to be doing this for every single recording that we have. And then we go to some of our customers, and what the really interesting thing said, Matt, if you're telling me that 30% of my patients have undiagnosed mental health disorders, I don't have the enough psychiatrists to see those patients. And I really point this out not to pass judgment on those systems. I point this out because it's a really interesting thought around what needs to change about healthcare are so many different things. It's not this one thing that you can solve and then all of a sudden everything's miraculously fixed, right? And I think that's the challenge of what we're talking about is we can use AI to solve this one problem in the value chain. But then in order for it to really drive, impact and get the level of adoption we need, so many other things also need to change, right? Like how it's being incentivized, how what evidence is being generated, what systems and whose P&L is coming from, right? All of these fail points along the way make it very difficult to drive the change we need in healthcare. And
Yeah, I
so
think
I
we need
think,
to be more specific also and, realize that we're past the wow era of AI. Wow, look what it can do. And really get very specific. All right. How does it help solve this particular problem? At what cost? What are the benefits? What is the data? And I think that we, not everybody has sort of made that transition yet.
yeah, yeah. Well, Dr. Shapiro, I know we're almost running out of time, but I do have one last question that I want to ask you that I ask all my guests. If there's one thing that you wished technologists like me knew about, the type of work you do or knew about an oncologist, what would that be? And vice versa, if there's one thing that you wish your community knew about technology or knew about some of the things that we've discussed, what would that be?
Uh, m- I'll answer the question a little tangentially, if I may. And that is my dream would be that you come and shadow me in my clinic for a day. That way, you could actually be a direct observer rather than have me present to you what my pain points are, because I may not be able to even see all the possible applications of technology to the work that I do or how it could be made easier. So that's my dream. And then at the same time, if you're actually spending a day with me and shadowing me, you would actually be able to feel, not just hear, what it means to really focus a practice, no matter what care you're delivering, whether you're doing, the most sophisticated cell therapy or the basic primary care, so that it puts the patient at the center.
Mm. Well, good thing that you're, a 40-minute drive away from me, and I might take you up on that offer.
That'd be wonderful. I mean it.
All right, Dr. Shapira, thank you so much for joining us today. I really enjoyed the conversation.
I did too. Thank you so much for the opportunity.
Yeah, of course.